Hello, my name is Carl. I'm a paediatric emergency medicine doctor. Today, we're going to talk about acute behavioural disturbance. In particular, we'll be looking at verbal de-escalation, sedation, and restraint. When managing cases of an agitated child, it can be helpful to consider whether the young person is in a certain stage of agitation. The following graph shows us the 6 stages of agitation. The first is when they are at baseline, when they are calm, cooperative, and their cognition and thinking is normal. The second stage is when they have been triggered. Acknowledge the trigger, show empathy and understanding, provide reasonable choice, and offer potential solutions. The third stage is when they have escalated. At this point, evaluate the environment for safety. In any communication, reduce cognitive demand. Remember, their cognition is poor now. Keep language, instruction, and options simple. Avoid too many choices. Limit the need for them to problem solve. And avoid, in the moment, any emotional labeling. Avoid saying, "Stay calm." If there is any hitting, kicking, throwing, self-injury, property destruction, remember safety first. Increase distance, reduce language further, decrease tone and volume, give space, and if possible, more time. Less may be more. Find out who knows them best, and also what has worked before. The fourth stage is that of de-escalation. The individual may themselves now be backing away. Any physical assault may have turned to verbal assault. They may be blaming others. This is an inverse of the escalation phase. Take this as an opportunity for positive reinforcement. Acknowledge the individual's de-escalation. Continue to model your own self-regulation techniques. Praise any positive behavior. Offer soothing stimuli, maybe a hot drink, a hot chocolate, maybe a soft toy. Reinforce any positive engagement, and very important, monitor for re-escalation. The last stage is that of post-crisis recovery. The individual may re-engage in the initial task that they were doing. They may withdraw or cry, they may fall asleep, they may ask about the consequences to their actions. Now's not the time, later. They may be overly apologetic or affectionate. They may express feelings of depression, a lack of self-control, or low self-worth. Knowing what stage of agitation the person in front of you is in is helpful. Important take-home points. When the person is at their most agitated, their cognition is much worse. The brain can literally shut down. So less communication is better than too much. Less is more. When things begin to improve, take this as an opportunity to learn about them and gain a rapport. Young people after a crisis often report either not remembering or not recognizing the person they were. You may be surprised to learn about their compassionate interests. They may like looking after animals. They may have creative interests like drawing. Try to connect with them and build a rapport. Get to know them. Of course, it is important to think about the physical environment. Can anything be improved? Are the lights too bright? Is there too much noise? Are things unfamiliar? Could there be more comfort provided? It is important to try and remain calm in voice and body posture. This should be intentional. Over 90% of our emotions and over 50% of what is spoken is communicated non-verbally. A working group of emergency psychiatrists noted, based on experience and available literature, that having a positive regard for the patient is more effective than any other method, tool, or formula for helping them de-escalate. Communicate empathy for their circumstances as part of their routine care. A goal of de-escalation should be to empower them to soothe themselves. So start off and take a breath. Be still. Consider using the following mnemonic to help remember tips for de-escalation. First, eyeball the situation. Get situational awareness. Respect personal space. Keep some distance. Assign one person to talk, not multiple people. Show active listening. Establish goals and limits. What are reasonable compromises? And reassure and provide, where possible, reasonable choices. Show interest, be sincere, be flexible, be positive, have a broad focus, avoid putting up a wall of professionalism, recognize misunderstandings, be transparent, model positive behavior and build trust. Often young people may not have had a strong attachment figure and may lack trust in health professionals. In addition to verbal de-escalation, there may be the option for cooperative use of oral medication. There are many excellent guidelines available. Here is just one example. Only in circumstances where safety is truly compromised and previous measures have failed should brief, planned restraint be considered, with the inclusion of an exit strategy. Please note, there are unsafe and safe ways this can be done, and anyone doing so should be trained or led by a trained professional. One possible goal of using restraint is to allow the safe administration of intramuscular sedation. This should be a last resort. Again, excellent guidelines exist, though wherever possible, medication options, both oral and intramuscular, should follow only after expert advice. It is easy to lose the perspective of young people in these challenging cases. Here we see how their prior experience perhaps were not considered. Efforts at de-escalation don't take the individual into account enough. My experience of racism and sexual assault have had a massive impact on how I experience interactions with emergency services. If you're supporting someone with learning difficulties, for example, your approach needs to take account of that. People don't understand how traumatizing restraint and sedation are. It's a violation that is very difficult to get over. I still deal with the mental scars from these experiences and have found it really difficult to get any information or support from services after the event. This is a traumatizing experience for emergency staff too. They need proper training and support. The only physical harm I experienced following a mental health crisis came from being restrained inappropriately. Distress doesn't kill, but the response to it can. The threshold for restraining someone is often really low. I have been slammed against the pavement or a wall because my behavior was deemed odd or eccentric. From a system perspective, much like with other emergency provision, we need to consider staff training, caseload and local demands, incident reporting to capture learning in serious incidents, metrics such as waits to be seen, time to medication, staffing levels, and violence and aggression statistics. Doing such allows us to begin to be proactive rather than reactive. Beyond today's talk, please let me recommend the following excellent resources. Firstly, for professionals, and then also for young people and families struggling with such challenges. The waiting room is a resource around mental health support in the London area, whilst Young Minds is a charity that can help in all parts of the country. Thank you. Thanks for listening. I'm hoping there'll be a video posted every week on various topics of paediatric emergency medicine. I look forward to seeing you again.